Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 135 of our pharmacotherapy MCQ series, which majors in infectious diseases. TKT, a 56-year-old male patient regularly presents to your accident and emergency department for catheter change once a month. His past medical history significant of quadriplegia secondary to spinal cord injury, type 2 diabetes mellitus, hypertension, chronic sacral decubitus ulcers, sacral osteomyelitis, neurogenic bladder requiring indwelling urinary catheter. He has foul-smelling urine, nausea, vomiting, and abdominal fullness that he has associated with urinary tract infections in the past. He missed a scheduled appointment 7 days ago. Some of his pertinent vitals include the fact that he is afebrile with a maximum temperature of 99.0 degrees Fahrenheit, a heart rate of 75 beats per minute, a respiratory rate of 18 breaths per minute, and a systolic blood pressure of 140 mm of mercury. He is admitted to your general medical ward. A CT scan with contrast is ordered. Some of his pertinent lab results include a WBC of 6 by 10 power 4 cells per millimeter cubed, a serum creatinine of 0.65 mg per deciliter, which was 0.3 mg per deciliter on admission. TKT's catheter is exchanged, a straight catheterization urine sample is obtained. The subsequent urinalysis reveals 50 to 100 WBCs, 3+ bacteria, and fewer than 10 epithelial cells per high-powered field with a positive nitrite test. The results of his urogram stain include oxidase-negative lactose fermenting gram-negative rods and oxidase-negative gram-positive rods, with individual colony identification and susceptibility test results pending. Which of the pathogens listed below, with the associated susceptibility, would you mandatorily report to the CDC National Healthcare Safety Network (NHSN) if cultured from TKT's urine if you were working in the USA? Would it be A. Klebsiella pneumoniae sensitive to meropenem, or B. Streptococcus agalactiae sensitive to doripenem, or C. Escherichia coli resistant to ertapenem, or is it D. Enterococcus faecium resistant to imipenem cytostatin? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Escherichia coli resistant to ertapenem. Escherichia coli resistant to ertapenem would qualify as a carbapenem-resistant enterobacteriaceae, which facilities should report to NHSN to contribute to national surveillance efforts. Currently, the only MDR-OS with CMS mandated reporting requirements are MRSA and Clostridioides difficile. Group B streptococci, i.e., Streptococcus agalactiae, do not need to be reported to NHSN. There are no reporting requirements for carbapenem-susceptible streptococci. Beta-lactam non-susceptible enterococci do not need to be reported to NHSN. There are no reporting requirements for carbapenem-resistant enterococci, such as Enterococcus faecium. Susceptible Klebsiella do not need to be reported to NHSN. There are no reporting requirements for carbapenem-susceptible Enterobacteriaceae. And the next question reads, assuming the pathogen infecting TKT above had beta-lactamase genes listed below, which one of them would most likely warrant classification of the patient's gram-negative uropathogen as a carbapenem-resistant Enterobacteriaceae (CRE)? Would it be A. SHV1 or B. TEM1, C. OXA48, or would it be D. CTXM15? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. OXA48. The OXA48 gene encodes the production of an Ambler class D carbapenemase. An organism harboring this resistance gene should be reported to the National Healthcare Safety Network as a lab ID event. The CTXM15 gene confers extended spectrum beta-lactamase production. However, it is not a carbapenemase, and an organism harboring only this gene would not be classified as a carbapenemase producer. The presence of CTXM15 alone is not sufficient to warrant reporting to the National Healthcare Safety Network as a lab ID event. The TEM1 gene confers low-level beta-lactamase production in Enterobacteriaceae, not serine carbapenemase production. The presence of Enterobacteriaceae with this gene need not be reported to the National Healthcare Safety Network as a lab ID event. The SHV1 gene confers low-level beta-lactamase production in Enterobacteriaceae, not serine carbapenemase production. The presence of Enterobacteriaceae with this gene need not be reported to the National Healthcare Safety Network as a lab ID event. And the next question reads, the infectious diseases consultant is brought on board to manage TKT's case. He reviews the patient's past medical history and microbiology history and identifies a urine culture history including Proteus mirabilis and Providencia stewarti whose susceptibilities were previously reported as follows. Proteus with a ceftriaxone MIC equal to 0.25 mg per liter, an imipenem silostatin with a MIC equal to 2 mg per liter, a nitrofurantoin MIC of 32 mg per liter, a ciprofloxacin MIC equal to 2 mg per liter. Providencia, with a ceftriaxone MIC equal to 0.5 mg per liter, an imipenem silostatin MIC equal to 4 mg per liter, a nitrofurantoin MIC equal to 64 mg per liter and a ciprofloxacin MIC equal to 4 mg per liter. Putting PK/PD principles into consideration, prior culture and susceptibility history, and antibiotic safety profile, which of the agents listed below is most likely to be effective for treating this patient's UTI? Is it A. ciprofloxacin or B. nitrofurantoin or C. imipenem silostatin or E. ceftriaxone? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ceftriaxone. Ceftriaxone achieves good urinary concentrations and is consistently active against the organisms that have grown in this patient's past urine cultures. Imipenem silostatin is inconsistently active against these organisms, and its use may result in poor outcomes due to the high MICs exhibited by these organisms against imipenem silostatin. Nitrofurantoin is inconsistently active against these pathogens. Providencia is intrinsically resistant, in spite of good achievable urinary concentrations. Although ciprofloxacin concentrates well in the urine, it is also inconsistently active and its use may lead to therapeutic failure due to elevated MICs. Additionally, fluoroquinolones should be avoided for UTIs when patients have alternatives according to recent FDA warnings. And the next question refers to the table below. I would advise you all to closely pause this video and closely scrutinize it before answering the question that follows. Both Klebsiella pneumoniae and Enterococcus faecium are cultured in TKT's urinary sample with the MICs and susceptibilities listed in the table below. So my question to you is, which of the antibiotics listed below would be the most appropriate initial therapy for TKK now? Would it be A. ceftolozane tazobactam or B. nitrofurantoin or C. ceftazidime avibactam or would it be meropenem? And the correct answer is D. meropenem. Meropenem would provide coverage for both the extended spectrum beta-lactamase producing Klebsiella and vancomycin-resistant Enterococcus faecium (VRE). This patient does not appear to require coverage for carbapenem-resistant Enterobacteriaceae at this time. Ceftazidime avibactam would be active against the extended spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the vancomycin-resistant Enterococcus faecium (VRE). The antimicrobial spectrum of activity is excessively broad for the Klebsiella and not fully active against the VRE, causing this patient's urinary tract infection. Nitrofurantoin would be active against the extended spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the Enterococcus. This VRE isolate would not be covered by nitrofurantoin due to resistance. The antimicrobial spectrum of activity is not fully active against the VRE, causing this patient's urinary tract infection. Ceftolozane tazobactam would be active against the extended spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the vancomycin-resistant Enterococcus faecium VRE. The antimicrobial spectrum of activity is not fully active against the VRE, causing this patient's urinary tract infection. TKT is treated with a 10-day course of systemic antibiotics after his catheter exchange for a catheter-associated urinary tract infection (CAUTI). The primary physician caring for the patient would like a recommendation for when to perform a subsequent urine culture. Which of the recommendations listed below describes the best evidence-based recommendation for screening for persistent bacteriuria in this patient? Is it A. Screening for bacteriuria is recommended after completing 10 to 14 days of antibiotic therapy, or B. Screening for bacteriuria is recommended after completing 7 days of antibiotic therapy, or C. Screening for bacteriuria is not recommended if the patient is asymptomatic, or is it D. Screening for bacteriuria is not recommended if the patient intermittently self-catheterizes? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Screening for bacteriuria is not recommended if the patient is asymptomatic. According to guidelines, screening for bacteriuria is not recommended for patients who are asymptomatic, regardless of whether they intermittently self-catheterize. 7 days is the recommended duration of antibiotic therapy for a rapid response in patients with CAUTI. Routine screening for bacteriuria is not recommended after completing 7 days of antibiotic therapy. A 10 to 14 day duration of antibiotic therapy is recommended for a slow response in patients with CAUTI. Routine screening for bacteriuria is not recommended after completing antibiotic therapy for this duration. Let's advance to the next slide, please. And the next question reads, KMP, a 67-year-old female patient presents to your accident and emergency department with a past medical history significant for a right-sided cerebrovascular accident with residual left-sided deficits 24 months ago, urinary retention complicated by UT is DVT, PE with resulting right heart strain, hyperlipidemia, atrial fibrillation and a heart failure with preserved ejection fraction. Today, she has a chief complaint of flank pain, nausea, vomiting, subjective fevers at home over the past 24 hours, recent decreased oral intake secondary to nausea and vomiting. Some of her chemistry results include serum sodium levels of 133 milliequivalents per liter, a BUN of 30 mg per deciliter, a serum creatinine of 1.2 mg per deciliter, an estimated CrCl of 60 ml per minute. Some of her pertinent vital signs include confusion, a body temperature of 101.3 degrees Fahrenheit, a heart rate of 100 beats per minute, a respiratory rate of 22 breaths per minute, a systolic blood pressure of 100 mm of mercury and a mean arterial pressure of 70 mm of mercury. So my question to you is, which of the findings listed below, in addition to the patient's initial presentation, would provide the most convincing evidence of a urinary source of infection warranting treatment? Would it be A. Pyuria, or B. Dysuria, or C. Hematuria, or is it D. Bacteriuria? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Dysuria. Symptoms differentiate asymptomatic bacteriuria from UTI. The presence of dysuria would be the most convincing evidence of a urinary source of infection in this patient's case. Bacteriuria may be symptomatic or asymptomatic, but the presence of bacteriuria without symptoms is not sufficient to make a diagnosis of UTI. Hematuria varies in prevalence and lacks specificity for a diagnosis of UTI. It should not be used as the sole criterion for treatment. The presence of hematuria would not be the most convincing evidence of a urinary source of infection in this patient. Pyuria varies in prevalence and lacks specificity for a diagnosis of UTI. It should not be used as the sole criterion for treatment. The presence of pyuria would not be the most convincing evidence of a urinary source of infection in this patient. And the next question reads, since her admission KMP was empirically treated for possible pyelonephritis with ceftriaxone 1 gram intravenously IV over 30 minutes every 24 hours. Assuming that she is now afebrile and tolerating oral medications and that her symptoms are responding well to antibiotic therapy on hospital day 3, which of the oral regimens listed below would be the most appropriate IV to oral conversion to treat KMP's urinary tract infection, UTI? Would it be A. Nitrofurantoin macrocrystalline 100 mg twice daily orally for 4 additional days, or B. Fosfomycin trimethamine 3 grams every 72 hours for 7 additional days, or C. Ciprofloxacin 500 mg twice daily orally for 4 additional days, or would it be D. Co-amoxiclav 500 mg stroke 125 mg orally thrice daily for 7 additional days? And the correct answer is C. Ciprofloxacin 500 mg twice daily orally for 4 additional days. Ciprofloxacin has been studied in adult female patients with complicated UTI and pyelonephritis. A total of 7 days of treatment appears non-inferior in efficacy to 14 days of treatment. This patient's clinical status is rapidly improving. Therefore, 4 additional days of ciprofloxacin for a total of 7 days of therapy is appropriate. While fluoroquinolones should be avoided when effective alternatives exist, withholding effective therapy does not represent optimal antimicrobial stewardship. Oral beta-lactam antibiotics are less effective than other available oral agents for the treatment of pyelonephritis and should be avoided when possible. Therefore, amoxicillin clavulanate is not a good choice for this patient. Trimethoprim, sulfamethoxazole or fluoroquinolones would be appropriate oral options for uncomplicated pyelonephritis. Fosfomycin trimethamine oral sachets should not generally be used for the treatment of pyelonephritis or febrile UTI because of low concentrations outside the urinary bladder. Pathogen MIC breakpoints are indexed to urinary concentrations. There is no evidence that extending the duration of fosfomycin treatment to 10 days will improve efficacy. Nitrofurantoin should not generally be used for the treatment of pyelonephritis or febrile UTI because of low concentrations outside the urinary bladder. There is no evidence that extending the duration of nitrofurantoin treatment to 10 days will improve efficacy in pyelonephritis. And the next question reads, KMP is now due for discharge to her home. Her discharge medication reconciliation reveals the following former oral home medications. Rivaroxaban 20 mg once daily, atorvastatin 20 mg at night, metoprolol 50 mg twice daily, multivitamin with magnesium, zinc, and minerals once daily, and calcium plus vitamin D once daily. The primary physician would like to restart all of her home medications at the time of discharge and asks you as the clinical pharmacist specialist to counsel the patient on her new home medications. Assuming that oral ciprofloxacin is prescribed, which of the following would be the most appropriate recommendation for how KMP should schedule her ciprofloxacin doses at home relative to her other medications? Would it be A. Take ciprofloxacin 2 hours before or 6 hours after her rivaroxaban, or B. Take ciprofloxacin 2 hours before or 6 hours after her multivitamin, or C. Take ciprofloxacin 2 hours before or 2 hours after her atorvastatin, or would it be D. Take ciprofloxacin 2 hours before or 2 hours after her calcium? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Take ciprofloxacin 2 hours before or 6 hours after her multivitamin. Ciprofloxacin should be taken at least 2 hours before or 6 hours after multivitamins and other products containing multivalent cations, e.g., calcium. Rivaroxaban and atorvastatin do not interact with ciprofloxacin. 28 days post-discharge, KMP returns to your accident and emergency department. She is afebrile and hemodynamically stable. Her chief complaint is dysuria, urinary frequency, with abdominal fullness and bloating, multiple episodes of watery diarrhea at home with an increase in frequency of episodes over the last 24 hours. Her urinalysis results included 3+ bacteria, more than 100 white blood cells, 5 to 10 red blood cells, and less than 10 epithelial cells per high-powered field with a positive nitrite test. Clostridioides difficile polymerase chain reaction (PCR) test is ordered to evaluate her watery diarrhea. Some of his pertinent lab results include a serum creatinine of 1.3 mg per deciliter, WBC of 22,000 cells per millimeter cubed. A urine culture and gram stain are ordered. Basing on her antibiotic exposure history and presentation, which of the antibiotic regimens listed below targeting her urinary tract infection would be most appropriate to initiating KMP at this time? Would it be A. Meropenem vabibactam 2000 mg/ 2000 mg IV over 3 hours thrice daily, or B. Ertapenem 1 gram IV over 30 minutes once daily, or C. Cefepam 1 gram IV over 30 minutes thrice daily, or would it be D. Ciprofloxacin 400 mg IV over 30 minutes thrice daily? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Ertapenem 1 gram IV over 30 minutes once daily. This patient has a recent admission and received multiple antibiotics within the last 30 days, making antibiotic resistance to fluoroquinolones and cephalosporins likely. Management with ertapenem appears effective and reasonable for patients like KMP with complicated urinary tract infection probably caused by extended-spectrum beta-lactamase producing Enterobacteriaceae. Recent hospitalization and ciprofloxacin exposure makes resistance to this drug likely, so it is not the best choice for KMP. There is an increased risk for resistance if the same antibiotic was prescribed in the previous 90 days. Recent hospitalization and antibiotic exposure make antimicrobial resistance including extended-spectrum beta-lactamase producing Enterobacteriaceae likely in KMP. However, cefepam is not a good choice for KMP because clinical outcomes data do not consistently support activity of cefepam against serious infections caused by extended-spectrum beta-lactamase producing Enterobacteriaceae. Although meropenem vabibactam is likely to be active against extended-spectrum beta-lactamase producing Enterobacteriaceae which may be called KMP's infection, it has a broad antimicrobial spectrum of activity that includes carbapenem-resistant Enterobacteriaceae (CRE). It is not clear that antibiotic therapy with activity against CRE is warranted for this patient at this time. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. On behalf of Dr. Nath Arawa, I would like to remind you that we look forward to interacting with you in part 136 of this series.